Hello, Namaste and good morning. Today I shall be discussing on otitis media with effusion. This is very important topic from examination point of view. OME is a common problem in children and this is one of the condition of reversible hearing loss in children. This is defined as presence of serous or mucoid fluid in the middle cleft without frank pause. Occasionally, organisms can be grown in fluid cultures taken from the middle cavity. The synonyms for OME are glue ear, serous otitis media, secretory otitis media, ceromucinous otitis media, exudative otitis media, and catarrhal otitis media. In the exam, you might be asked to write synonyms of otitis media with effusion. The question will be like this. Define otitis media with effusion. Write 3 synonyms of the same. Now let's come to etiology of otitis media with effusion. The most common cause for OME is staging tube dysfunction. The children are prone for staging tube dysfunction because of adenoids or frequent URTI that leads to vacuum in middle ear and extravasation of the fluid in the middle ear that leads to collection of fluid. Staging tube dysfunction also leads to lack of drainage of middle ear secretions because the middle ear secretions come from the middle ear to the nasopharynx. So if there is staging tube block, then they cannot come down. That leads to accumulation of fluid that is called as OME. Next is upper respiratory tract infection or allergy. That also leads to increased middle ear secretions because the tubotympanic portion of the middle ear cavity has respiratory epithelium. So there might be presence of goblet cells which can secrete the mucus. Low-grade middle ear infection or inadequate treatment of ASOM or acute otitis media also might lead to presence of fluid. ASOM, as you know, is an infective condition. So once the infection subsides, the fluid might not resolve. That might lead to otitis media with effusion again. What are the symptoms of OME? The most important symptom in children will be decreased hearing in a young child that increases during URTI. OME usually occurs in children, either preschool going or in the school going children, around 2 to 3 years one peak and 6 to 7 years next peak. Therefore, the children as they go to school, they might have decreased hearing, or children staying in home also might have decreased hearing. The children with OME will watch the television with a higher volume than other members of the family, so they can diagnose the child is having decreased hearing. And sometimes the child speaks loud, or occasionally the child might not reply on what the parents are telling. The child might complain of mild ear pain. There might be blocking sensation in the ear. The children might tell they have oral fullness. And the child occasionally has delayed and defective speech due to deafness because the child cannot understand what others are speaking. There are certain signs to be seen on otoscopy. They are dull or pinkish or blue eardrum with restricted mobility is the important finding. The TM becomes dull or pinkish, occasionally blackish due to fluid inside the tympanic membrane and in the middle ear. In early stages, as there is staging tube dysfunction, the tympanic membrane gets retracted, and in late stages, the tympanic membrane bulges out because of presence of fluid in the middle cavity. On examination, we can see fluid level and air bubbles inside the tympanic membrane or middle to tympanic membrane. And if we examine the Seagal's pneumatic speculum, the fluid and air bubbles might move. Tuning fork test can be performed in compliant children. Few children might not be compliant. So if they are compliant, the tuning fork test shows conductive deafness. You can see here, this is blue eardrum. The eardrum is blue and this is retracted eardrum. You can see ear fluid level here. This is the fluid and this is the air bubble. You can see here. This is the fluid, the crescent shaped. We can see air bubbles here. The air bubbles signify there is again presence of fluid in the middle cavity along with the air. The clinical examination is enough to make the diagnosis, but in certain instances, we have to do the investigations. And they are Impedance Audiometry. This shows low frequency conductive deafness. Fluid in the middle cavity acts as the mask, as well as the tympanic membrane might be stiff. Therefore, there will be low frequency conductive deafness in children with otitis media with effusion. Impedance audiometry, there will be C-type tympanogram in eardrum retraction, that is early OME. But when there is fluid in the middle cavity, there will be B-type tympanogram. This is B-type tympanogram, you can see here. And this is the C-type tympanogram, which is found in early stage of OME or retraction of the tympanic membrane. Sometimes X-ray mastoid and X-ray nasopharynx lateral view are also important. We can see clouding of air cells in X-ray mastoid occasionally, and adenoid mass can be seen in children. This is the adenoid mass, which is obstructing the upper airway. So there is upper airway narrowing narrowing of the nasopharynx, and that leads to extrusion tube block and OME. Now let's come to treatment of OME. Antibiotics are the mainstay of treatment, but they are not used to treat the fluid. They are used to treat nasal, nasopharyngeal or throat infections so that the fluid might resolve. Culture of fluid from the medullary cavity in few children have shown presence of organisms, so they are useful to treat the organism as well if they are present. Antibiotics can be given for 2 to 4 weeks. Second is nasal decongestants, either systemic or topical form. They help to decongest the nose and the extrusion tube shall open and fluid might pass from the medullary cavity to the nasopharynx. H1 antihistamines, they are antihistaminics, so they will open the nose and they will also make the medullary cavity dry. Autoinflation of the extrusion tube by Politzerization maneuver helps to flow the fluid from the medulla to the nasopharynx by opening the extrusion tube. When the child complains of pain, we can give analgesics. We frequently use low-dose oral steroids and steroid sprays, supposing that the extrusion tube will open and the fluid might resolve, because steroids are also anti-inflammatory agents. Now, non-medical and non-surgical treatment. There is certain role of non-medical and non-surgical treatment. They are Politzerization, Otovent balloon, ear popper device, and the ear dog device. They are not very commonly used, but when the child is not compliant to medicine, then we can use these alternate ways. Politzerization. A rubber tube attached to the Politzer bag is put into the nostril and both nostrils are pinched or closed. This is the rubber tubing and this is the Politzer bag. Now, patient is asked to swallow repeatedly and Politzer bag is squeezed simultaneously. What happens? As the Politzer bag is squeezed simultaneously, this air also goes to nasopharynx and helps to open the closed extrusion tube. Next is Otovent balloon device. In this case, balloon is inflated by blowing air out of nose. When fully inflated, balloon neck is pinched off and nasal occluder is inserted into the one nostril, so the one nostril will be closed. Now, the child is instructed to swallow as balloon is inflated into the nasal cavity. In this case, one nostril becomes closed and next nostril is open, and that helps to increase the airflow towards the nasopharynx, leading to opening of the extrusion tube. The portion of air from the balloon enters the extrusion tube and ventilates the medulla. This is the basic theory behind Otovent balloon. It's a simple principle. Our basic aim is to open the extrusion tube as much as possible. You can see Otovent balloon here. The balloon is being inflated by the child. Next is ear popper device. This is also based on Politzerization. The device delivers a safe, constant and regulated stream of air into the nasal cavity. During swallowing, the air is diverted to the extrusion tube, clearing and ventilating the medulla. All these non-surgical, non-medical equipments, they help to open the extrusion tube and thus ventilate the medulla. The ear duct device generates and transmits special vibration waves which travel through the temporal bone to reach the medulla and extrusion tube. The waves thus generated is the medullary pressure and drain trapped fluid. So they basically make the thick secretions thin and they help to drain the fluids. In this case, edema and pain are also reduced. The ear duct device also helps as a massager, or it helps to massage the mastoid portion of the temporal bone, so the thick fluids are made thin. When medical and non-medical non-surgical treatment fail, then the child has to undergo surgery to remove the fluid from the medullary cavity and to ventilate the medulla. The most important surgical treatment for OME is Myringotomy and Grommet insertion. Myringotomy is also called as tympanosclerosis, and the Grommet is also called as pressure regulation tube or ventilation tube. In Grommet, the T is silent, so you can simply tell Grommet also. In OME, a radial incision is made in the anterior-inferior quadrant of tympanic membrane and the fluid is drained out. We simply make a radial incision, not circumferential. In radial incision, we simply separate the muscle layer of tympanic membrane, so it can easily be healed. When the fluid is thick, then we make two incisions, one in the anterior-inferior quadrant and next is anterior-superior quadrant, so-called Pierre-Can principle. When we make two incisions, it will be easy for the fluid to be drained because there will be aeration from one side. Next surgery is cortical mastoid surgery for refractory cases with loculated fluid in the mastoid. So as we saw in the previous X-ray, the mastoid also can be involved. There might be clouding of the mastoid cells. When there is clouding and when there is accumulation of fluid in the mastoid, we can do cortical mastoid surgery, but this is rarely performed. The most important surgery is myringotomy and Grommet insertion. So next is treatment of predisposing factors. When the child is having adenotonsillar hypertrophy, we can do adenotonsillectomy. When the child has sinusitis, we can do enteral wash or suctioning. Or when the child has nasal polyps, then we can do polypectomy. So our basic aim will be to open the nose and the nasopharynx and the eustachian tube. You can see here, this is the process of Myringotomy. This simply means making a hole in the tympanic membrane. This is the tympanic membrane. We are making a hole here and we are draining the fluid. This is Myringotomy. Okay, so this is the Myringotome. This is the knife. This is waist-shaped knife. So the advantage is, in usual cases, this is around 2 millimeters. So we need not traumatize the middle space of the medullary cavity with the help of this sword-like thing. The incisions made for myringotomy are the anterior quadrant of tympanic membrane, anterior quadrant, which is safe. In posterior quadrant, there will be presence of ossicles. So anterior quadrant is safe quadrant. Beer-Kent principle, making a hole in the anterior superior as well as the anterior quadrant. We usually don't make a hole in the posterior superior quadrant because there is presence of ossicles. The basic idea of making hole in the anterior quadrant in eustachian tube dysfunction is this area is nearby the eustachian tube, anterior portion. Therefore, the medullary can be well ventilated when we make hole over here. These are different grommets. This is Sequelae grommet and this is Sahaj grommet. The grommet is inserted through the tympanic membrane to the medulla. One end lies in the medulla and next end lies in the external auditory canal. And the grommet comes out by usually 6 months in most of the cases. This is called as extrusion of grommet. After surgery, you can see here, this is the grommet outer part and this is tympanic membrane, which was retracted earlier. Now also it's retracted, but there is no fluid in the medullary cavity. The grommet extrudes on itself after 6 months due to endothelium growing on its inner surface. This picture shows healed tympanic membrane after extrusion of grommet. Still, the TM is retracted and the TM is also thin. It seems that there is collection of fluid in the medulla. You also might be asked regarding the complications of grommet insertion. They are tympanosclerosis. As the healing process, the TM gets whitish patches due to increased collagen deposition. The TM might get perforated, especially when we use the long-lasting grommet might not heal properly. So if it does not heal properly, we have to do myringoplasty. In some cases, there might be formation of granulation tissues in the tympanic membrane that is called as myringitis. Occasionally, the grommet can get lost inside the medulla. In this case, we have to remove the grommet back again. Now, we'll come to sequelae of O.M.E. So, if not treated, what can otitis media of the effusion do? It can lead to TM atrophy and atelectasis. It can lead to adhesive otitis media, tympanosclerosis, cholesterol granuloma in the medulla, ossicular necrosis, or retraction pocket and cholesteatoma formation. So, there are chances of complications due to O.M.E. If we find out O.M.E, the maximum we can wait is for 3 months. If the child does not improve by 3 months, then the child has to undergo surgery in the form of myringotomy and grommet insertion, or when the child has other predisposing factors that have to be controlled, especially adenoids and the tonsils. Thank you very much. I think the class was useful to you. You can always refer the textbooks if you have any doubts. Thank you.